Thanks for showing up. That you knew it was me, or if you didn't know it's me. I see a lot of familiar faces. And I'm not a PowerPoint person, really, so who knows what's going to happen. But my niece helped me out, and this lovely lady here, Harper was very helpful before. So movement magic, aging joints, and what we can do. Anybody have any ideas? That's why you're here, right? What was that?
Keep moving.
Yeah! See, okay, we're done. Let's go have cookies. All right, so we're going to identify cause and symptoms, treatment, explain different types of arthritis a little bit, explain the treatment plans, and outline how you can manage and minimize. What is arthritis? So arthritis itself, arth is joint, itis is inflammation. And so that's where the name comes from. So it is a joint disease. That protective cartilage, that cartilage that's in your knee, the juicy, flexible tissue wears down, and it can allow the bones to rub together. We're going to kind of specifically talk about osteoarthritis today, which is that wear and tear. But there is psoriatic arthritis and rheumatoid arthritis, which you might have heard of or be familiar with. And those are autoimmune diseases. So it's a little bit different process, right? Because then the body is, even though the symptoms are similar, the body is attacking your tissues. And so those are very specific and autoimmune and can be genetic or environmentally triggered. With osteoarthritis, which is the most common, the research that we have really focuses on hands, knees, hips, and spine, but mostly knees and hips. All right, so let's see what else I got. It is a leading disability for those us mature adults. 1 out of 5 are affected in our population. And as I said, knees, hips, hands are the most common. So we look at the populations. Of course, again, we're looking at our maturity. Women more than men, heavier, more than slender. I thought this was interesting. I didn't know this when I was getting ready, that non-Hispanic American, Indian, and Alaska Natives have a higher propensity. Education, also there is some correlation with that, and poverty. And I would guess if you were looking at the ecological part, or looking at those things, if you don't have access to health care, chances are that disease or disease process is going to be more prevalent. The other thing that which is good for us to learn, I guess, is that we really should be talking about arthritis when we start being active, which is when we're young or younger. Because one of the biggest things is trauma or injury. And so I think the Arthritis Foundation and lots of the ups in arthritis are really working with the youth and sports in particular to look at decreasing injury risk. Because once you're injured or once you've had that trauma, your chances to have arthritis increase in that area. And also we see an increase if we have lots of falls, which happens sometimes as we get more mature. So injury prevention is very important. So with your grandkids or your kids, just really talk about how important it is to try to prevent injury. We've got better equipment now. I think there are better training programs out there, but it's super important because when we're young and we get hurt, we just keep playing, right? So that we call that primary. So that's the intervention before health effects occur. The secondary is early stages of disease before onset. And that's where we're going to talk about healthy lifestyle And tertiary, that's managing a disease. So some of us here, me included, already have arthritic changes. I remember I'd had some thumb pain, going to Mayo Clinic, and I was taking my mom there for an appointment. I thought, well, I'll just, my thumb's kind of bothering me. I'll just have this, I'll just go to the ortho department while I'm there. So they took films, and the PA came in, and he goes, well, I said, he talked to me a little bit. He goes, well, have you seen your mom's hands? And I said, yes. He goes, well, some of it is genetic. So he said, and you use your hands. I mean, my job is I'm using my hands every day. So chances are I'm going to have a little bit of arthritic change. All right. Let's see. What are signs and symptoms of arthritis? Let's look. You're looking at stiffness, swelling, and pain. Everybody raise your hand if you've had any of those things, right? And some of us, I kind of alluded to this before, but the trauma, injury, overuse, genetic propensity, obesity, the increase of body mass, you have increased load. Certain occupations, like with heavy lifting, repeated stress on a joint. Some metabolic diseases, too, can lead to that, diabetes. And some bone deformities that we don't necessarily have control over that, but also can be at risk. Note that older adults with self-reported arthritis, this is just a note, visit their physician's office more frequently and experience greater functional limitations than those of the same age group, which also makes sense. When you have the whole joint involved, you can see bone remodeling, which means the bone itself is changing shape. You can have osteophytes, or what we call spurs, little pieces of calcium that have grown. You can have, I had said before, cartilage degradation, which means the cartilage itself is getting less and less and less. And synovial inflammation, that's that covering, that shiny stuff. It can get red and angry. All right. The duration of arthritis, it tends to worsen over time, but we like to think that we can do some things to prolong that, right? It is not yet reversible, but we have one trick up our sleeves, or up our legs, or in our bodies, and that is to, say it again for me. Move. That's right, gotta move. And we will in just a moment. About that, duration. What are different treatment options? I think it's really important. There is no one specific treatment, because if there were, we would all be doing that. But your treatment program has to be individualized, and it has to be comprehensive. I think we would like to have medication available to us that would really help. And NSAIDs and Tylenol can be helpful, right, for pain. But that isn't a cure, but it can allow you to, and we'll say it again, move better. I think it's also important, like these lectures that you've been attending this summer, education is so powerful. So if we understand the disease process, or we understand what's happening in our body, then all of a sudden it makes more sense to us. And it isn't just so, frustrating. Or just like, well, I used to be able to do that. Well, and when my clients say that to me, I said, yeah, I used to be able to do a flip off the diving board too. But I'm not doing that anymore. So it's not, I like us to think of what we are doing instead of what we can't do. So I think it's really important, and that leads into the psychosocial part of it, because I know from myself from my husband's experience of having arthritis, when you can't do a thing that you love, it's hard. And so you can either think about that you're not doing it, or you can modify, or you can start looking at your world in a way of saying, well, I can't run a marathon now, but you know what? I can do a 5K, and I can walk it part of the way, and that's a lot. So starting to think differently about what you're doing, I think, is really important. We'll talk a little bit more about the physical, that's right up my alley. And I did allude to the pharmacological things. What is interesting, though, is that isn't, when you've looked at all the studies out there, NSAIDs and Tylenol, but it is rarely recommended that you do any kind of narcotic for that pain. And we do know about steroidal injections. Some of you may have had them. But the steroidal injection is to bathe that area with an anti-inflammatory in order for you to, Bailey, move. That in itself is not a cure, but it allows your joint to move with less discomfort. And that movement and the vascularization that you get from that movement is what can be really helpful in getting you more active, right? Okay. Let's see. All right, we talked about this. Patient-driven. Like I said, there's no clear template, and it depends on every individual. And I hope that I, as your provider, would say what's important to you. If I say, okay, Carolyn, I want you to go and I'd like you to do trampoline exercises because that's what I like to do, right? Or you pick anything. But it's the best exercise we do, or the best exercise we have available to us is the one that we do. If you hate swimming and I suggest you go swimming, right there's a disconnect, right? So when you go to your providers, I would hope that you would say, really what I really love is A, B, and C. This is hard for me because of these things. And then your provider can say, well, let's work on some modification, or let's do this, because if you're motivated to get out and ski, then I want to help you with that. You might not be able to do, like Cole likes to show me how much elevation he's done, for the weekend. You might not be able to do that, but you might be able to do 3 runs. And that's great. So kind of thinking, making sure it's individualized, all right? The other thing I think is really important, next slide. Oh, this is kind of what I was talking about. We're talking about interventions. I just copied this from PT magazine. And the light gray or the darker gray that you see is strongly recommended, though white is conditionally. The dark gray, strongly recommended against, and no recommendation. So what I want you to pay attention to is that top line, exercise, hand, knee, and hip, along with self-efficacy and self-management programs. And all that means is that you're going to take control of your program. But everything else is conditional, which is kind of fascinating, really, right? So from an exercise perspective, we're talking about the recommended treatments: exercise, weight loss, self-efficacy, and self-management. These are specifics, and I'll go into a little bit about that the CDC has recommended, like Tai Chi. Braces, certain braces for hands and knees are helpful. Kinesiotaping, this got misspelled, and Bailey and I tried to fix it today, but no. And again, although there is not enough evidence to recommend a certain exercise over another, it is known that supervised exercise, those folks tend to do better, which is a big bonus for me because I supervise exercise, or Bailey and I supervise exercise every day. And so that was really encouraging to me, and what would I say, validates what I'm doing with my clients. And not that you should be supervised forever and ever and ever, but to start off and to get a good program going, it really helps to have somebody there that's working with you. And also what we found is that in post-PT, if you're in a class, or even if you're taking an online class, if it's something that's supervised, those folks tend to do better. So. Weight loss. This is a hard one, right? Because if your joint hurts, how do we lose weight? We move. But if my joints hurt and I can't move, that's really challenging. So oftentimes with my clients, we'll talk about that. What are some ways? Can we do some low load exercise, cycling, swimming, even doing, I have done things where I have clients sit and trying to get your heart rate up, because getting your heart rate up is good for your tissue, but it also helps in weight loss. Nutritionally, there's quite a bit out there. You have to really read between the lines, but there is good science behind kind of anti-inflammatory type of eating. And there's been some study about omega-3s, right, for our joint health. So there are things out there. The supplements available to us that many of us have taken or are taking, the science is not always 100, is what I would say. But it's not going to hurt you. I don't know a lot about the supplements. I try to read from a PT standpoint, and I take supplements. But would you agree, Bailey? But the science is not hard science yet. And you know how I love hard science. Okay, then getting next. Okay, the CDC, if you've ever looked on their arthritis site, they do have specific exercises that they have found to be helpful. And I don't know, you guys someone might be able to correct me, but I don't know if any of this, I know Tai Chi is available here in Fairbanks, but some of these are very specific programs. Active Living Every Day, Arthritis Foundation Aquatic Program, the Arthritis Foundation Exercise Program, Enhanced Fitness, Fit and Strong, Walk with Ease, group and self-directed. I think the self-directed you can do online, but this is an excellent website to go CDC and just put in arthritis prevention. And it describes the classes, but essentially what you're working on, your benefits are increased physical activity, function, cardiovascular fitness, range of motion, muscle strength, decreased pain, decreased fatigue, decreased depression, increased confidence. So all the things that we're looking for that we find have been successful in arthritis management and prevention are found in these programs. And there it talks about the population, benefits, content, and intensity. And I like that they said the intensity because it ranges from low to moderate, which is good. So you can pick what works for you. Again, looking at your individual treatment plan. Oh, and I like that they had the instructor qualifications. Like, not just Joe off the street, that they have to have some type of training, which I think is good too. So, what does it say? It would be horrible if I made you sit this entire time. Who took the stairs up here today? Excellent, me too. Okay, my slide, my niece helped me do this PowerPoint, and it had music on it, but my friend Harper and I couldn't find it, so I'm going to just play this on my phone, and no judgment. This is a no judgment zone, right? So we're just going to move, and you can follow me or not, okay? And the name of the song is Move. All right? Arms up. We're going to go here and here, side to side. Beautiful. Look at that. You're feeling better already. All right, then we're going to go ooh and up. All right, that's a little too boring. Find some space. Here we go. Up and back. Up. It helps if you do that. Ready? And again, up. All right, now here, this is for the advanced class. All right. Other side. All right, back to beginning. Perfect. All right, now we're going to go do a little cat and cow. Take it, push and pull. Ready? Front and back. Front and back. Front. When I see you guys at Fred Meyer's, I'm going to expect this kind of a greeting. Right? All right. Back to hips, right and left. Side to side. All right, now let's do a little bending forward. And roll it back. And one more. Going a little deeper. And then go a little deeper. Back to our legs. Perfect. And then you want to sing. Move. Move. And then take it out. And see, I'm switching it up. See you move. Let me see you move. Okay, now get ready for the end. You're going to do a little pose. Perfect. That was, thank you for obliging and participating. Because, you know. But if it doesn't feel good to stand, we could do so many of those things sitting. We do it all the time at the clinic because sometimes it doesn't feel good to stand, but you can still move, and I want you moving. And the other thing is working on strength. So one thing I wanted to share with you today is just breathing. When we inhale, we relax that diaphragm and our pelvic floor and our abdominals. When we exhale, we are engaging those muscles. And that can be really helpful in transitional movement, sit to stand, when you're walking, when you're doing anything. So I want us all to take 3 deep breaths, diaphragmatic. Exhale. Do it again. Exhale. And I want you to pay attention on this next breath. What is your deep abdominal layer doing? What do you feel? Do you feel engagement there? So let's take a deep breath in. Exhale. So if I am going to get up from a chair. I'll go by down here. And I feel like I want to use my maximum amount of strength possible. I would take a deep breath in and exhale. Because then I know that my core is engaged and it's helping me in supporting my spine. And even if you're not here, everybody is breathing. Everyone in this room is breathing. And so that is a great way to start on a program, is to breathe. Well, except for one. There's always one. Anyway, but so think about that while you're doing your regular activities at home. Whether it's filleting a fish, or if you're rolling over in bed, or if you're doing laundry. I mean, the million tasks that we are required to do to live. Just think about incorporating that breathing, and you'll be strengthening this trunk and your pelvic floor, which is very important. All right. So just kind of thinking about our treatments. When we educate, there's a positive effect. Physical activity. Don't you all feel better now? You just moved a little bit? Positive. Psychosocial, also positive. Weight management, positive. Sleeping, I didn't really talk about that. It wasn't as much of an effect as some of these other things, but it's still super important. And we know that our bodies regenerate, or, that is their time to heal from the day. So it's so important to get good sleep. And multidisciplinary, just meaning incorporating everything. With increased pain and with less activity, remember, movement is healing. And we talked about sleep, self-management, your ability as a patient to manage that treatment through lifestyle changes and I love that this is my niece, and all the other things. But what she is alluding to is all the other things we've talked about, the psychosocial, the self-efficacy, and then it's easier to manage arthritis when you are supported by other people. I think that's true in life about many things. So if you already have arthritic changes, there is no way to reverse it. We talked about that. I always like to say, yet. There's all kinds of stuff out there, and many of you may have heard of things that I don't even know about, but trying to grow cartilage in a petri dish, and 3D, well, this is not so out there anymore because they're doing it. 3D printing for arthritic prosthesis for your knee or your hip, that people are already doing that. Playing around with different types of injections. You have the some of the ortho guys are doing, or men and women are doing the injections that kind of mimic cartilage. That's just a short-term kind of effect, but they're like when they first started doing that. Remember, it was the rooster comb, and now it's the hydrochloric acid or whatever it is. But I mean, it's always evolving. That's the cool thing about medicine. Oh. Thank you for participating. And do you have any questions, or is this what you expected? That's why I try to tell my clients. Is this what you expected? Were you disappointed? Leave a note at the door.
Ruth, I have a question.
Yes.
And be important to repeat the question so it's picked.
Oh, yeah.
But what about ankle weights or chest weights or any of that? Good, bad, and different?
So Mike asked, what about ankle weights, chest weights, those kinds of weights? I'm guessing when you're participating in a cardio thing. I don't know. Again, I don't know that the science is strong regarding that. I would wonder why you were doing it, because if you're getting your cardiovascular, but I do think if you're going on a sheep hunt, or if you my oldest boy is a smoke jumper, you have to carry load. So if that's part of what you do for a job, I think, yes, for sure you should practice with that. But I don't know, just I don't add weights when I'm doing the elliptical or teaching jazzer. Now, along with that, I would say, but it's important to do resistance training. So you need to, I feel like, especially as I have matured, I feel like I need to do more rather than less. I do more strength work. I am doing, I would say, more challenging workouts than I did even 10 years ago for strength. Lift weights. I do a lot of just body weight stuff because it's easy and you can do it anywhere. So planks is my go-to because it's so efficient. You're going to work upper body, core, and legs. Yeah?
Would that be yoga, ma'am?
Well, let's just show you what it is. They do planks in yoga, but I'm just doing it like this. And you can have your knees down and then just put them up briefly and then work your way up to more time. Or if I do it that way because of my wrists and my fingers have what? Arthritis. So the forearm is a little more comfortable for me. But in yoga, yes, we do go into a plank and then, you know, yeah.
What about adaptations for shoulder?
If you have, what I've found with my shoulder patients, and Bailey, she can share with me too, is that I find when you're doing forearm, you're able to do it. But what you could do is you could go start on a wall, right? And so then you're not loaded, you're not having your full body, but you're still getting the benefit of that. Anything else?
Yeah.
Yes, Don.
I've been a patient, and I highly think that this kind of physical therapy is wonderful, and also have always been very reluctant to have surgery. That's kind of a last, in my opinion anyway, a last choice rather than a first choice.
Right.
We're in a small community, and a lot of people end up, getting major surgery at a very early age. Is there some way one can not insult, but discuss with a physician who suddenly wants you to, have a hip surgery, knee surgery, whatever,
Right.
especially with joints?
Well, so the question was in discussion with your provider. In discussion with your provider, if you're looking at alternatives, maybe to a surgical intervention. There's a lot of things with that question. One, what is the injury? Remember, it's all patient-based. So what's the injury? Because some things need to be repaired, and like a ACL tear. Well, it doesn't need to be repaired, but for most people, especially if you're very active, that's going to be, so that's an example. But I think what you're alluding to is more like total joint replacement or something like that. What I would say is, and was Dr. Kerr here last week? Next week. And I think he's going to talk about that, right? What I would say is that the orthopedic surgeons that I have ever had contact with, they, at least with my experiences with prosthesis or artificial joints, they'll say, you'll come to me when you're ready. It's when you start losing function, right? When you can't, what I see in my clinic is that you've been walking 2 to 5 miles regularly, 5 to 7 times a week. But then your knee hurts. So then you just walk the dog for a little bit. But then your knee really hurts. So then you let the dog out the door. And then your knee really hurts and it's hard to get out of that chair. So that's kind of the progression I see. I mean, I'm making light of it and I don't mean to, because that's devastating for us when we lose our ability to do things. It's not fun. It doesn't feel good. But what I find is that orthopedic surgeons that I work or have worked with, they'll say at that point, like when you aren't able to do your regular daily activity things, that's when you'll come to me. Now, I would say, you know, I've been lucky enough to do this fantastic job for 40 years, you know, and I love it. It's just the best job. And what I've seen, you know, if you would have talked to me about a total knee patient in 1988 and what I see now, it's totally different outcomes. The surgeries, I think, are quicker, which means that you've, you know, less trauma in a way. They get you moving immediately. Immediately. When I first started practicing, cranking on those knees 3 weeks out, yeah. And if you got 90 degrees of flexion, which is this much, your surgeon was happy. That is not the case anymore. People get 125 to 135 degrees of flexion, which is pretty much normal. And so things have really changed. And the same with hips. So we are starting to progress with ankle replacements because that's a big issue, but there's not as much study about that. And we're getting smarter about backs too, because we realize surgical intervention there can sometimes, the long-term outcome is not so great. But in any of those cases, I would say you would always want to make sure, of course, I'm going to advocate for physical therapy because that's what I do, but at least do some type of prep strengthening range before you go into that surgery. You want to have your best outcome, and your best outcome is going to be if you have the most motion and the most strength possible. So, irregardless of if that's the end goal, because no surgery is the best surgery, but that's not always possible, right? And my husband had a partial knee. So he still walks like a horse, but, you know. Yeah?
A question. Can you talk a little bit more about the food, the inflammatory food, or
I
food
kn-
that causes inflammation?
Yeah, she asked about the inflammatory food. Well, we probably all know sugar, you know, those kinds of things. All the things that we love are the things, no. But an anti-inflammatory diet, you can look at, I don't feel like I'm an expert. I would really talk to a nutritionist. But I know we're lucky here in Alaska with our salmon and blueberries, and I think cherries are anti-inflammatory. Dark green leafy vegetables. A really good, healthy, plant-based diet with fish, I would say. Would you agree?
Yeah, following more the Mediterranean.
Mediterranean, yeah, type of diet. Yeah, so the processed foods, those things tend to inflame. And there's a whole other science about natural supplements that like I said earlier, I'm not familiar with, but I feel like if you feel it's helping you, then it is helping you. Any other questions? Yes.
This is an odd one, but this has already been said to be no, but the thing is when I was working a warehouse job, I was a little bit older. Point being is that I would take certain vitamins,
Yeah.
and then they seem to
Help?
actually get rid of the problem in my joints
Yeah, I think it's great.
by lining them.
Because I think there's a lot that we don't always know either. And I say if it makes it better, then it's better. That's what I say. Uh-huh.
Could you talk a little bit more on weight loss impacts on the joints?
Yeah, yes. Increased load, just increased load is going to affect your joints. And what I was reading is that if you can see a change in the load on the joint itself. if you have a greater or equal to 5% weight loss, which I thought was manageable. You know, I mean, it's easy. We've all had those situations where you go in and say, well, you know, let's lose weight, but how do we do that, especially with joint pain? So I try with my clients, and especially if that's what they want to do. Again, you know, it's not for me to. I mean, I can give you the information, but I'm team you. You know, if when Carolyn comes, I'm team Carolyn. If Bailey comes, if Margot comes, I'm team Margot. You know, I want to do what you want to do. Otherwise, our treatment session is not going to be successful. So if weight loss is part of that treatment, then we can talk about that, and we can talk about lots of things that lead to successful weight loss. And a lot of them include kind of cognitive things, you know? So that's what I would say. But yes, it definitely impacts the joint. And I have, this is just my personal experience, but I had an injury from actually a massage therapist down at Alyeska, and kind of tweaked my femoral nerve. And if any of you have had nerve pain, it's not fun. And I thought, well, maybe this is as good as it gets. And so when that happened, I made an effort. I was healthy, but I thought I'm going to lose some weight, because if I have to drag myself around like this, I want it less. And it was slow but effective. And what was interesting to me, I did notice a change. You know, I exercise every day, but I did notice a change. I felt like I could go longer and do a little bit more because I didn't have any joint pain. So I don't know. That's just a personal thing. Any other questions?
When you talked about supplements, were you including things like glucosamine, chondroitin?
Right. I think you're to use them together. Again, this is not my expertise. She's asking about the supplements. They don't hurt you. That's what I know. But I do feel like one of the classes I took, continuing ed classes for PT, they talked about how that industry isn't regulated the same as, say, you know, stuff that you are prescribed. So you have to be very cautious about looking at the ingredients. You know, why would you take, 3 tablets of this glucosamine, but only 1 tablet, but they're the same size? And so you just really have to look, because they can use a lot of fillers in some of those. And I know they did, but this is years ago now, they did a test to see if what the ingredients said, if the pill was what the ingredients were. And the one that was accurate, 1 out of the 7 that they tested, was Bioflex. But that was years ago. I don't know if that's still the case. So it's still Bioflex, yeah. So you just have to be cautious with that. But I don't think there's anything inside them that can hurt us. And if they make you feel better, don't we all want to feel better? I say go for feeling better. Yes. Yes.
Is that the same as like turmeric?
Turmeric is a plant, so it's a little bit different, but a lot of people do turmeric, yeah. And again, I don't know about it, but it helps people, so. Yes.
Is there a, I don't know, way isn't maybe the right word. If you're having a joint problem, is it sometimes possibly a good idea to go see a PT first? Before you
Always.
see an orthopedist?
Yes. Always. Yes. Well, not necessarily. But what I would say is that, and part of it is insurance driven. So, as if you have Medicare, it's going to require a prescription. So, you would have to, not have to, you would elect to see your provider. But I feel like our community, the providers have been awesome if you ask for PT. Very rarely have I ever had a client that's come that said, they don't want me to come. Rarely. You know, and I've been doing it a long time. They're great. Again, they should be Team You. If that's what you want, then that's, and if anything, it might not change, like I was telling Dawn, it might not change the outcome. There might be surgery in your future, but you're going to know more, you're going to feel better, you're going to be more confident because you are stronger and you've worked on your range of motion or whatever it is. And I think it helps. I have had situations where patients have gone and had surgery, not necessarily in town, but outside, and the follow-up, because they're doing a lot. They're doing hundreds and hundreds and hundreds and hundreds of knee replacements, so they're really good. But then sometimes the follow-up, and so no one knows what to expect, which is, I think the more you know going into any kind of medical procedure, your outcome will be better because you're educated and a lot of that stress of what to expect. What I find is that, for example, with my total knee clients, they'll have their first one, and I should do a little study about this. If you look at the time for recovery, when they have their second one, which is on their other knee, because they use that leg so much, it's always shorter. Because they know what to expect. It's probably not 100% of the time, but a big part of the time, their rehab is cut by a couple of weeks. Because you know what you should be doing. All right? Don't ask me any hard questions. Right? Any? Go ahead.
Just a couple of things. When Ruth and I were setting this up last winter, we had talked about Dr. Kerr. In fact, he follows next week, and his topic is arthritis surgery victory.